Welcome to Wellness Wednesday. It's another Wednesday where we talk about just health in general on a lot of different topics. I'm Carla Coleman. I'm the Director of Communications for New Salem Baptist Church. And I have with me my co-host, Paige Reynolds. Paige, you want to say hello?
Good evening, everyone.
Great. So we're happy to be here another Wednesday. We're here tonight to talk about women's health, woman to woman talk with Dr. Dana Moulton. And she's an OBGYN here in Columbus. And she has a number of scenarios actually about women and some good advice on things you should do. What we're going to do tonight is we're going to go through her presentation, but we're going to stop after each of her scenarios and put some questions in the chat. Really fill up the chat based on what the different topics that we're going to discuss tonight. So I'm going to hand this on over to Dana and get started because I know we're going to have lots of questions. I, as a woman, have lots of questions, so we might as well get started as soon as possible. So let me go ahead and share her presentation. Before we do that, just say hello, Dana.
Hi.
So here we go. All right. I thought we were going quickly, but they're not. Sorry, hold on one second. All right, go ahead, Dana. Tell us a little about yourself.
All right, thank you so much, Carla. And I'd also like to start out by thanking the New Salem Baptist Church for inviting me to talk to you all this evening. We are going to start out today by just talking about women's health. So I'm going to give you guys a couple of scenarios that I see in my office on a daily basis. And hopefully in some of these scenarios, you will see possibly some of the issues that either you've had or your mom or your sister or your daughters have had. And you can just pop some questions on the chat and just ask away. So we'll go on to the next slide. We're going to start out with a little bit about me. And I have to say, you know, my husband put all this on here about me, so I don't want anyone to think I'm really huge at this self-promotion. But I was born in the beautiful city of Shaker Heights, Ohio, which is outside of Cleveland, just north of here. I live in Powell, Ohio. I've been in Columbus now for 25 years, and I have been a member of New Salem for about that long. I got married there. I am married. I have 2 children and a fur baby. And I did meet my husband and got married at New Salem 22 and a half years ago. Some of my free time, I'm a mom Uber. I spend a lot of time driving my children around to their various activities, but I love to scrapbook. I love to garden when it's warm outside, and I am an avid sports fan. So for all of my Browns and Ohio State Buckeye fans out there, I see you. I am a member, some of my affiliations, I am a member of Delta Sigma Theta Sorority Incorporated, as well as Jack and Jill of America Incorporated. Before I came to Columbus, I spent 4 years at Cornell University in Ithaca, New York, and I did a non-traditional major by majoring in English, as well as being pre-med. Came here to Ohio State to do some graduate work, and then after which I went to the University of Cincinnati for medical school. After medical school, I had to move up north to that state up north, Ann Arbor, Michigan, to do residency at their community hospital, St. Joseph Mercy. And then we moved back, and I've been here ever since. I've been in practice with one big practice here in town for 13 years. And then I've recently, about 2.5 years ago, moved over to Ohio Health Physicians Group, where I'm currently an employed physician in practice in Hilliard. So that's a little bit about me. So we're going to move on to these scenarios and save up your questions, because right after we're done with this, we're going to get some questions answered, okay? So patient number 1 that I see in my office is a 45-year-old woman who comes in for her female annual wellness exam every year. She's married, she has 3 children, and she has no major medical issues, so she's a very healthy patient. During her exam, she does ask about her 16-year-old daughter who has a boyfriend, and when she should start having her daughter see the gynecologist. So just a couple of points about an annual exam. I'm sure you women out there go in every year to see your gynecologist and you love that appointment. I hear that a lot on a daily basis. Parts of an annual exam, of course, include your breast exam, a pap smear, and a pelvic exam. And depending on your age, it could also include a rectal exam. Your gynecologist might ask about any new health history, medicines, allergies, your plans for fertility. They also ask about your menstrual history, your sexual history, and any of those sorts of things. Want to hone in a little bit on the pap smear. Some of you come from the generation, I know I do, where you get your pap smear done every single year. And that's what you know, that's what you want to do, that's what you come in asking for. But within the last, I would say 5 to 15 years, we have found there's this little virus called human papillomavirus, also known HPV. And HPV is the virus that we know is that causes cervical cancer and cervical precancers. And so since we found that virus and we actually can isolate it when we do a pap smear, you now do not need to come in every single year to get a pap smear per se. We do test for HPV. If you have HPV, then you will fall into that category where you do need to get pap smears on a more frequent basis. However, depending on your age, you might only have to get pap smears every 2 to 5 years. And so that's something you should talk about with your gynecologist. There's a huge algorithm that looks at your age, your risk factors, your sexual history, your past pap smears, and they will determine whether or not you need to come in every 2 years, every 3 years, or every 5 years. There's also a vaccine that I want to tell you guys about. Vaccines are really huge these days, but there's a vaccine that's called Gardasil, and it is the HPV vaccine. And it's recommended for children at this point from ages pretty much 11 to 12 and off label, and I'll tell you about that in a second, you can get it up to age 25. Initially when I'm sorry, 45, I think I said 25, it's 45. Initially when it came out, it was recommended for women up to the age of 26. And unfortunately, insurance companies haven't quite got on board with that 45 prolongation. So we do recommend it for women, girls between ages 12 through 26. If you're under 14, it's a series of 2 shots that you get 6 months apart. If you're over 14, it's a series of 3 shots that you get 0, 2, and 6 months apart. It's also indicated for boys, and I'll tell you why that is in a second. And it does protect you against various high-risk strains of HPV. Does that still mean that you can get an abnormal pap smear? Absolutely. There are hundreds of strains of HPV out there that can cause problems. And the vaccine only protects you against about 9 of them. So it is still important to see your gynecologist and talk to them about when you need to get your pap smears. But we do recommend getting that vaccine for your daughters and for your young women if you haven't already. I did talk about the boy part. HPV vaccine has been indicated to give to young men. And the reason for that is young men can pass HPV unknowingly to their partners. So I have had women who have come in after their honeymoon where they've gotten married and their boyfriend, their husband was their first and only relationship, and they have an abnormal pap smear. And they're devastated because they're like, why? And that's because their partners have become exposed to HPV at some point in their reproductive history and didn't know it. So they unwittingly gave it to their partner, their wife. So that's why there is the recommendation for boys to be vaccinated, and we do recommend that as well. The last piece of that patient case that I wanted to kind of throw out there was the daughter. At what age do you send your daughters to the gynecologist? I get that question quite a bit. And some parents will drag their 15-year-old daughters into my office, and you have these wide eyes and just frightened stares from these girls thinking about what I'm going to do to them on the exam. You do not need to bring your young daughters in to get a pap smear until age 21. Even if they've been sexually active. We do recommend, if they're sexually active, to come in before age 21 to talk about things like HPV vaccine and HPV, to talk about STD prevention, to talk about birth control, but we don't recommend that they have a pap smear until age 21. It's also recommended if you have a daughter under the age 18 or 21 and she is sexually active, that they do get tested for gonorrhea and chlamydia and any other sexually transmitted diseases before age 21 as well. Lastly, if you have a daughter who's struggling with her periods, heavy periods, painful periods, mood disorders, you can bring them in and we can talk to them about that as well. So that is patient one. So if there's any questions that you want to put in the chat, you can go ahead and do that. And I will be happy to answer them about scenarios with patient one.
Well, I just had one question, and that is, what are some of the symptoms of HPV? I'm sorry, I get it wrong every time.
Yep, HPV, absolutely none. There are no symptoms of HPV. Usually we find HPV incidentally on a pap smear when we do it. Sometimes if we have someone who HPV has damaged their cervix to the point where they do have transformations in their cervical cells, abnormalities in their cervical cells, then you might see symptoms of cervical damage. So bleeding, irregular periods, bleeding after intercourse. Sometimes you can have a lot of discharge, a lot of odor, things like that once the pap smear has actually started to change. But infection with HPV is completely asymptomatic, and a lot of people don't even know that they have it. The other thing about HPV is it's a virus. So when it comes into your system, depending on the strength of your immune system, it actually can go dormant for decades. And you have normal pap smear after normal pap smear after normal pap smear. And then one year you have an abnormal pap smear. And women wonder, well, what happened? And it's because their immune systems were so strong that the HPV just didn't show up for all that period of time. Women can also clear HPV. So we do know that our younger women, ages 21 through 30, their immune systems are so strong that they can clear HPV over time as well too.
So Paige, do we have any questions in the chat?
No questions in the chat yet. However, regarding the vaccine, how long is it effective for?
Well, it's supposed to be effective for a lifetime. There is no booster for the HPV vaccine, at least it's not recommended at this particular time. But like I said, when I started residency, I think we had like maybe 5 or 4 HPV strains that we knew about. And since then, we've now climbed up to way more than that. So are there other HPV strains that are mutating and becoming variants that can cause damage that the vaccine does not cover? Absolutely.
Okay.
Okay, so maybe we can go on to patient number 2.
Okay, patient number 2.
Right, let me put the slides back up here.
Okay, so patient number 2, she is a 35-year-old woman who comes in to see her gynecologist for a long history of very heavy periods. They're usually spaced apart every 28 to 30 days, but recently they've been coming every 2 weeks, and they are so heavy that sometimes she soaks through her clothes. She sometimes has had to leave work early due to the accidents that she's had. And she's also noticed that she's been feeling really tired and sometimes dizzy. So this is a very, very common patient scenario that I see in my office almost every day, sometimes 4 or 5 patients a day. I call it when good periods go wrong. So let's first talk about the normal period. So generally a woman will start having periods anywhere between 9, 16. And usually when she first starts having those periods, they are irregular. Sometimes they don't come at regular intervals. But once you get to about age 21, period usually shows up between 28, 30 days, usually lasts for about 5 to 7 days. And your heaviest period is somewhere between your first day and your 3rd day, and it goes away. But every once in a while, your period will deviate. And why that happens is a big deep dive into ovulation and hormones and things like that. So and on this Wellness Wednesday, we don't have time for all that. But when a period gets irregular, you could see it every 2 weeks. It'll start and stop. You might have spotting. The period can last for more than 7 to 10 days. or you could just literally soak your clothes, have clots. And of course, these are things that really affect a woman's activities of daily living. They usually can't go to work, or they can't do regular things they can't with their friends. They have to be very careful with their clothes, things like that. So the question is, oh, and I forgot to say this, you lose so much blood with these periods that you start to become anemic. And that's where you could get really, really tired, feel dizzy, don't want to get off the couch. It can be very distressing for women. So we generally lump, things that cause this into several categories. The first category, of course, is hormonal issues. So things like your thyroid, which is the gland that's right here in your neck, which is your major metabolizer, can either go too fast or go too slow, and it can cause your periods to be abnormal. There's also a hormone that comes from a little tiny organ in your brain called pituitary. It's called prolactin. And prolactin is responsible for creating milk for lactation. And if you start kicking out too much prolactin for various amount of reasons, that can cause you to have irregular periods, heavy bleeding. And then we check your CBC, which stands for complete blood count. And that blood level gives us a couple things for information. It tells us first if you're anemic and how anemic you are. And it also tells us your platelet count. Platelets are part of your blood that cause you to clot. So if you're a kid and you skinned your knee or you got a paper cut or something like that, you'll notice after a couple minutes, it'll clot. And your platelets are the blood cells that are responsible for that. So sometimes especially in younger women, we will see that there are abnormality in those platelets. And when there's an abnormality in their platelets, they can't clot and they just bleed. So we look for those sorts of things. The next category that causes this sort of irregular bleeding, what I call lumps and bumps. So those are lumps and bumps that could be on your uterus, the biggest of which is fibroids, and we'll talk a little bit about that a little bit later. But you can also have what are called polyps in your uterus. And polyps are like little skin tags that you get on your skin, like little moles, but you get them inside of your uterus, and they are not under hormonal control. So they're like little naughty children at the store who want candy. They just do their own little thing, and they just bleed and bleed and bleed. And we find those on ultrasound. There's a specialized ultrasound that we can do to find those. And if we remove them, then we can remove all that heavy bleeding. And then the last but not least cause of, the most concerning cause of bleeding could be precancer or cancer in the uterus. And we usually see that with older women. So if I have a woman who comes in after menopause who hasn't seen a period in years and she starts bleeding, that's a red flag. For women who carry a little bit more weight, we know that they make lots of estrogen, and that can stimulate the uterus. So we look for that as well too, by doing a procedure in the office to take some of those cells out to make sure that there's no cancer or precancer. That by chance is also the least likely reason for your irregular periods. The biggest reason for your irregular periods is a hormonal imbalance. As women, we make two major reproductive hormones, estrogen and progesterone. And to my patients, I have an English degree, so I tend to be pretty descriptive. I kind of explain it as your front lawn. So most people have a front lawn. The grass grows in the spring and the summer. It's beautiful. It's lush. And if you put fertilizer on your front lawn, it grows. And if you put too much fertilizer, it will burn. But if you put a reasonable too much fertilizer, it's going to grow and grow and grow until it creates those little fuzzy things that kind of fly all over the place, and weeds and things like that. So you got to go mow your lawn. So the lawnmower comes out, mows the lawn, and you have these grass clippings that you have to deal with. Well, that's what your uterus is like. So the lining of your uterus builds up every month because of estrogen that comes from other parts of your body. And then at the middle of your cycle, when you ovulate, that hormone generally turns to progesterone, which acts like a lawnmower. And it comes along, mows the lawn, and then the grass clippings come out as what you know as a period. Mm-hmm. Well, sometimes your ovaries and your hormonal system, they don't get along. They don't communicate well. They don't talk to each other well. And you'll get either too much estrogen, AKA fertilizer, or the lawnmower just refuses to work. He's just not coming out. And so you'll get those weeds, and then everything goes awry. And that's how you get that irregular period. hormonal dysfunction. And there's lots of different reasons why we have hormonal dysfunction. You could be stressed, you could have lost a lot of weight, you could have gained a lot of weight, you can be an athlete, lots of different reasons that your hormones can be out of whack and cause this sort of irregular bleeding. And there's lots of things that we kind of do to kind of help with that. They start with basically using things like oral contraceptives, Depo-Provera, which you might have heard of. There's a device, an intrauterine device called a Mirena, which is a 5-year device that's implanted in the uterus and acts like an in-house lawnmower to keep things nice and tidy. And then there's surgical things that we do. There's a non-invasive procedure called an endometrial ablation, which some women might have heard of. And that's where we scorch the lawn. So we go into the OR and we just burn all that lining off. And it's 90% effective. We generally do not recommend that for women who are still planning to give birth to children in the future, because it can affect your fertility. And then last but not least, there's your garden variety hysterectomy. That will definitely fix the problem. But generally these days, we tend not to use that as a first line, because surgery does have some unwanted side effects as well too. Mm-hmm. So any questions about that? I know that was a lot.
Yeah, any questions in the chat?
No questions in the chat. That I just want to say that was a really good explanation of how it works, like every single month, and what can change. I've never thought of it like that. So, but could you give some tips for, obviously if you have other problems you need to come in to see, but for girls or women who do have heavy periods, the cramping is like horrible. I know I have that. What are some tips that you give, that home remedies that you could do?
Yeah. So the first home remedy, especially with the cramping, which can be with the bleeding, but can also be separate from the bleeding, is the first thing is use your ibuprofen correctly. So we usually recommend that non-steroidal anti-inflammatories, which use your Aleve, your ibuprofens, that you try to start taking those at least 24 to 48 hours before your period. Now, of course, if you're not on something like the pill or something that's regulating your period, or if your periods are irregular, it's really difficult to figure out when your period's going to come. But if you have an idea, try to start that ibuprofen at least a day before your period is to start. And then take it every 8 hours while, during the part of your period that is the most uncomfortable. So don't just start taking it when you have pain and then the pain goes away and then you stop taking it, because the pain will come back. So you want to keep that steady state of medication in your bloodstream to help with the cramping. There's some other things, some stronger anti-inflammatories that can come from your gynecologist that they can also prescribe that will help. Things like a heating pad helps, a nice warm bath helps. And then if all those things generally don't help, then that's where we start talking about, do you need to be on a birth control pill to kind of help lower some of those hormonal inputs to your uterus, to help control the cramping and to help control the bleeding. You can also toggle birth control pills where you do it continuously. So instead of having a period every month, you end up having a period about 4 times a year. So you take the pill continuously for 3 months. So we're kind of tricking your body by only having a period every so often so that you don't have the symptoms.
Yeah, that was great. So now we have a couple of questions. What are some of the reasons women are afraid to get yearly exams?
Well, I'm going to tell you the first reason that I hear with every patient, and it's that darn speculum. And I'm going to give a shout out to a friend of mine who calls it the spreader. That is a hard stop for a lot of women, and it's scary and it's uncomfortable. It's also very intimate. I mean, I don't know many people who, feel comfortable with almost a complete stranger, especially if it's a new gynecologist, being in your intimate space like that. So it's a little daunting. Also, some of the issues that women need to discuss are sensitive, and they don't feel comfortable sharing those sorts of things. So it's really important when you're looking for a gynecologist to find someone who makes you feel comfortable and makes you feel at ease. If it's your first visit, We do have special speculums or spreaders for all different sorts of body types. So we have pediatric ones for our younger population. We have what's called first timers for women who are a little bit older, but definitely need something smaller. And then we have larger one, and we don't want the larger one, but we have all sorts. But really just finding someone that you feel comfortable with and who's going to explain things to you so that you take away some of that fear of the unknown.
Yeah. So when searching for an OBGYN, if you are a new patient, besides obviously someone you want them to make you feel comfortable, what should you be looking for, like specific things?
Well, there's a lot. So, and I'll kind of touch on that a little bit at the end of my talk. But finding someone who shares your philosophy. We talk a lot about fit. So when you meet someone and you talk to someone, finding that doctor who really forms that fit with what you need from them. Someone who, if you're someone who needs a lot of explanation, a lot of discussion, you want to go to someone who has more time in their schedule to do that. It's really, if you want a woman, that's important to some women. You don't want to go to a practice that potentially may have some males, just because you might have to see that male from time to time. And if you know that you're not comfortable with that, you want to think about that. Also, in terms of cultural things like that, you want to also, if you speak a different language, you want to make sure that they have those sorts of resources in their office to be able to translate for you. So there's a lot of things. Usually when you walk in and you meet someone, and that's kind of like first impressions, when you walk in and you meet someone, you kind of know if they're going to be a good fit for you or not.
Yeah, definitely. So another question, if you have gone through menopause, should you take a hormone replacement, and what does it help?
Okay, that is a very good question. And I'm actually going to pause on that question.
Okay.
We have a patient coming in who just might have that issue in just a second.
Okay.
All right, we want to go on to patient number 3 now?
Yep.
Okay. There's patient number 3.
All right, this is patient number 3. She is a 27-year-old female who comes into her gynecologist to discuss some increased growth that she's noticed in her lower belly. And when she presses on it, she feels like there's something hard in there. She's been feeling some increased pressure in her pelvis, and her periods are heavy and they're really painful. So this slide touches on one of the reasons that we have heavy bleeding from the last patient. And this is a huge buzzword. It's the fibroid, also known as, its medical term is leiomyoma or leiomyomata. So fibroids are very common, very, very common. And what they are benign growths of the muscular layer of the uterus. And so I'm going to just kind of scoot over to the next slide for a second because I have a picture for you. There you go. So in this picture, you can see a schematic of the uterus that has several fibroids. You can have fibroids that stick off of the uterus, kind of like a lollipop. I don't know if I can use a pointer at all. There we go. So the pedunculated fibroid, which is up here at the top of the uterus, is a fibroid that sticks off of the uterus like a lollipop. If you come down to inside of the uterus, you have a submucosal fibroid. So those are fibroids that actually grow into the lining of the uterus. And we tend to see women with large amounts of bleeding with those. The fibroid, yep, that's another submucosal as well too. If you go right down, you'll have an intramural fibroid. And those are fibroids that actually grow within the muscle of the uterus. Those can cause a lot of pain, a lot of discomfort. They also can cause bleeding as well. And then if you go across the street from him, there's your subserosal fibroid. And those are fibroids that kind of come under, so there's a blanket, a sheet over the uterus called the serosa. And those are fibroids that grow in that serosa. And those can get very, very large, distort the uterus, press on things in your belly, and cause a lot of pain. The picture next to the schematic are actual pictures of fibroids that I have taken out of someone, and they range in size. So the fibroid that you see at the bottom, that's about as large as a kidney. And then you have little itty bitty ones up at the top. Interesting, these things, they're sneaky. So we've had women who with very, very large fibroids who have absolutely no symptoms. And then we have women with very, very small fibroids who have all sorts of symptoms. Women can have more than one of these. Women can have just one of these. They can come off of any part of the uterus. I've had patients whose uteruses are pretty much up to their rib cage because they're so big. And we quantify them in terms of size, and we equal it to the size of a pregnant uterus. So these are our fibroids. Generally, the mantra is, if fibroids aren't bothering you, we leave them alone, because the treatment for them becomes pretty invasive pretty fast, especially if you're a woman of reproductive age. So fibroids grow. They're not cancerous, but they do grow. They can grow very big and very fast. The treatment for fibroids pretty much surrounds cutting off either their blood supply, which feeds them and causes them to grow, or their hormonal supply, which also feeds them and causes them to grow. So we can do anything from putting a patient on birth control pills to slow their growth, to help with the bleeding, to help with the cramping. There's also IUDs you can use to help with bleeding, but it doesn't stop the fibroid from growing. And then there's more invasive things that you might have heard about. There are fibroid embolizations, also known as uterine artery embolizations, where we block blood flow to the fibroid and cause it to shrink. And then last but not least, there's also your garden variety hysterectomy that'll take out the uterus. A note about that: if you're reproductive age and you want to have children, clearly we cannot take out your uterus. So there is a procedure called a myomectomy, which is how I got these fibroids, where we go in and we shell out the fibroids and leave the uterus alone. That can help a woman with fertility, help her to bear a child. It also subsequently can go the opposite way too. So it's something that you want to talk about with your doctor. There is a very new treatment modality that utilizes both MRI and ultrasound to shrink fibroids. Not a lot of people in town are doing that here. There are some centers across the country that are doing that. It is considered experimental for a lot of insurances, and there's coverage issues, but it is out there. I also wanted to put out there that we don't know what causes fibroids. We do know they are very, very common in African-American women. We don't know why. We do know that there are certain diets that will exacerbate their growth, but we still haven't figured out the pinpoint, why do these things grow in some women and not others? Why do they bother some women and not others? We don't know the answer to that yet.
That was going to be my question, because I know a lot of women very close to me who have, serious fibroid issues, have had hysterectomies because of their fibroids, huge issues. And it just seems like mostly, all I've known are African-American women who've dealt with this.
Yeah. It is very prevalent in the African-American community. And we do know that there's a genetic predisposition to them as well. So I've had lots of patients come in and they're like, my grandmother had fibroids, my mother had fibroids. And I'm like, well, do you think you have fibroids? Well, I don't feel anything. And sure enough, they have fibroids. And we don't know why. We haven't unlocked that yet. And I'm hoping that that's something that, we'll be able to research in the future and figure out.
Is there a way to screen ahead of time, just to make sure?
Well, the first thing that we do to screen for fibroids is the physical exam. So generally, a woman who has fibroids, her uterus is enlarged. Usually the uterus is below the pubic bone. So if I have a patient whose uterus is above the pubic bone, then that kind of gives me an inkling there might be something going on. If that's the case, then we move towards an ultrasound. And an ultrasound is gold standard for actually looking at fibroids, seeing how many fibroids you have, where they are. And if you're concerned about a fibroid, like it doesn't look right on ultrasound, you can then follow that up with an MRI. And that will help you really kind of pinpoint how many fibroids you have. But more importantly, it will make sure that that fibroid is truly benign, because there is a very, very, very small risk of malignant transformation of a uterine fibroid. And you want to make sure before you, just kind of say this is a fibroid, that you're not dealing with something more severe.
Okay. Gotcha. Any questions in the chat page?
We do have some questions. Is it safe to get pregnant during the COVID-19 pandemic?
Oh, wow. Okay. Well, the short answer to that is absolutely. You cannot, delay life because of the COVID pandemic. Yes, it is. And in fact, we've seen a boom in women getting pregnant during the COVID pandemic. Not sure what's going on there. But yes, it is safe. I mean, there are things that you will have to think about. The protocols change every day. So, will your partner be able to be with you for visits? Will your partner be able to be there for the ultrasounds? Will your partner be able to be there when you deliver? Things are constantly changing based on the numbers and the exposures. But yes, it is very safe and totally fine to get pregnant during COVID.
Great, great. That's good to hear. Any other questions?
So what is the age for the first exam for a young lady?
Okay. Yeah. Just to reiterate, 21 is when she really needs her first real big gynecological pelvic exam with a pap smear. But sometimes we will do it earlier if a young woman is having problems, if she thinks she's been exposed to a sexually transmitted disease, if she's having problems with her period, then we would do a pelvic exam sooner than that.
Mm-hmm.
That sounds good. I think we can go to our next patient.
Okay, we'll go to the next patient.
All right, patient number 4. So we have a 48-year-old woman who comes into her gynecologist for just not feeling right. She's gained about 40 pounds over the past several years, and she's having a hard time getting it off despite a good diet and exercising regularly. She's tired all the time, and her coworkers have told her that she seems really grumpy recently. She is married, and her husband tells her that he feels he can't do anything right by her at any time. And her children have been complaining recently because she always wants it to be cold in the house. So this is what we would call, and I didn't tell you what her period profile is, but she is still having periods. So this is what we would call our perimenopausal patient. And there is a delineation between perimenopause and menopause. So menopause is the time of life where a woman has gone 12 months and her period has not shown up. Once a woman gets that 12 months and her period has not shown up, we consider that menopause. Average age for that is about 51. I do have some patients who are past that, and I do have some patients who are before that. Generally, if we have a woman who's gone through that in like her early 40s or late 30s, we consider that premature menopause, and we would do a huge workup for that to see why that's occurring. But for most women, age 51 is the average age that you're going to go through menopause. Perimenopause is the period in time, it's also known as premenopause, where you start to go through that transition. And the transition really comes from the ovary. So when you're born, you have all these wonderful eggs that could potentially become children. And every month you lose them. And then once you go to menopause, they're gone, no more eggs. So during the time of perimenopause, you don't have a lot of eggs, and your ovary is what makes your hormones. We talked about that estrogen before and that progesterone. So your estrogen and progesterone profiles are all over the place, and your body goes right along with them. That period is about 10 years before you go through menopause. So if average age is 51, then generally between 40, 41, you start to go through this transition. It's a slow transition. So it starts, and a lot of women don't even know they're going through it. They might feel a little bit more weepy at a commercial, or their partner is getting on their nerves a little bit more. Their kids are getting on their nerves a little bit more. Their periods might be getting a little wonky. When they're outside, they might feel a little hotter than usual, but it's summertime, it's 90 degrees. Of course you're hot. So it's a very slow transition for most women. But by the time you get to about 48, 49, 50, you really start to feel like there's something going on. I call it the menopausal, perimenopausal basket because there's a whole bunch of symptoms that go into perimenopause. These are the symptoms that show up before menopause. You're still having periods, and you're like, well, what can I do about this? Because I just feel horrible. The long and short is there is no magic bullet for perimenopause. We do have hormone replacement therapy for women who have gone through menopause, and we'll talk about that in just a little bit. But perimenopause, it's really trying to help to deal with the symptoms that a woman is having. So you can start birth control pills to kind of help stabilize the hormones that are causing some of the issues. If you're having vaginal dryness, there are preparations that you can use to help with that. If you're really moody or irritable, we can use mood stabilizers to help with that. But there isn't really that perfect magic pill that you can take to help you get through the perimenopausal period. And trust me, I know because I am that 48-year-old woman. Now, when you get to menopause, if we have a woman who comes in and she's having horrible hot flashes that are really affecting her activities of daily life, then we might consider hormone replacement therapy for that patient. And I say might because hormone replacement therapy does come with some unwanted side effects. And those biggest unwanted side effects are they do increase your risk of breast cancer, and they also can increase your risk of cardiovascular disease, heart attack, stroke. And so we definitely don't want to do harm to any patient while trying to offset their hot flashes. There are some other things for hot flashes for women who can't or do not want to take hormonal replacement therapy. There are mood stabilizers that actually will help with the areas in the brain that cause hot flashes. There's also some other medications like gabapentin. And then there's also alternatives. So there's your soy, your black cohosh, evening primrose oil. Those are sorts of things that can also help to alleviate some of the symptoms. I actually know I found a product at Costco called Estroven, and I like Estroven. So not that I am promoting any product, but that one is a very good one. For women who suffer with vaginal dryness and pain with intercourse in their later years, there's also vaginal preparations that we can use to help with that. I always say the vagina is a use it or lose it sort of organ. So once you lose your estrogen in menopause, the vagina does become very, very dry. It's not as flexible as it used to be. And that causes a lot of grief and distress for women. So there are preparations that you can use to help offset some of that. And I would talk with your gynecologist and they can kind of list some of those. I have found a lot of them sometimes aren't covered by insurance, which is very, very upsetting. But they are out there, and it's really just working with your provider to find the best fit for you.
Yeah. So if you've gone through menopause prior to age 51, should you have a workup or not?
It depends. So if you're 40 and you've gone through menopause, or if you're 39, absolutely. You should talk to your gynecologist and see why that is. If you're 48, 47, probably not. That's probably when you were due to go through menopause.
Okay. And can you share your thoughts on regular mammograms versus the 3D screening?
Yes. So the gold standard for mammography is a breast MRI. Insurance companies are not going to pay for breast MRIs unless, of course, you have an increased risk, a high risk for having breast cancer. So whether you have genetic testing that puts you at a higher risk, or you have relatives, first degree relatives that put you at a higher risk. So there is the mammogram. There are a lot of mammograms out there. There's digital, there's tomography, there's 3D, and it really depends on where you go. A 2D mammogram for most women who don't have very dense breasts is totally fine to do. But for some women, and the radiologist really kind of guides you in terms of what's best for your breast to see what they need to see. So if they're not seeing what they need to see, you need to have that discussion with the radiologist to find out what mammogram is best for your breast tissue. So it really just depends on the patient.
Okay. I think we had a question from YouTube. So 1 second. Can you see that, Carla?
No, I can't. But while you're looking
Oh,
for
I see. She says, hello, ladies. Not sure if you've touched on this, as I just hopped on a few minutes ago, but are labor-like period pains something to be concerned about?
So labor-like period pains, that means that your pain on a pain scale is like 10 out of 10. And so absolutely, I can't really see how you can function on a daily basis with having that sort of pain. So yes, I would definitely talk to your gynecologist. We kind of touched on painful periods a little bit earlier. And if you've been taking ibuprofen, you've been doing all this stuff at home, you want to talk to your gynecologist and definitely get an evaluation, see why you're having those sorts of pains, and then see what can be done about it.
Just to go back quickly on the, premenopause and menopause, when you are having hot flashes, and many of us have had those.
Amen.
Amen. What can you do? I mean, there's, what works?
Outside of hormone replacement therapy, which is not recommended for women who are still going through periods, there's not a lot. And it's really sad and distressing that there's not. I could give you a big soapbox speech as to why that is, but I will spare you today. The first is getting a good fan. That's the first thing. And like I said, birth control pills, a lot of my 40-year-old women are not interested in going back on birth control pills. And that's just the truth. And some women can't because they either smoke, and we're not recommended to give you birth control pills after 35 if you smoke, or they have other issues that preclude them from taking birth control pills. But that is one way that we can, because the reason that you have you have these hot flashes is these hormonal spikes that actually work on your brain to cause you to have this spike in temperature. So the thought behind that is if we stabilize your hormones, that we can, get rid of some of those hot flashes. If you're not interested in birth control, then I kind of steer people towards things like Effexor or Paxil. Those are mood stabilizers, like I said, that work at the brain to help with hot flashes. There's another neuromodulating medication called gabapentin. Has a lot of side effects though. And so do Effexor and Paxil. These are women who are in their 40s. Libido does take a hit in the 40s. And some of those mood stabilizers exacerbate that hit. And women are not interested in that. Estrogen, Costco, pick it up. And then there's your things like your soy, black cohosh, and things like that. That does remind me, I do want to touch on, if you watch TV, I know I do, you've got a lot of these places that are offering like the magic bullet. Yeah. Come on in and, I feel like I'm 20 again. You got to be careful with some of those. Some of those things are what you might have heard the term bioidentical hormones. They are out there. They are not regulated by any sort of FDA entity. You don't know what you're getting. A lot of them are hormones. They could be combinations of estrogen. They could be combinations of progesterone, combinations of testosterone. And I will tell you, testosterone that'll give you your libido back. It might also give you a mustache. So, it's things that you need to watch out what's in these things, and you don't know what you're getting. Sometimes you could get a cream that has absolutely nothing in it. Sometimes you can get a cream that has too much medication in it. And I have had patients that have had some unwanted side effects from getting a compounding bioidentical hormone that had too much medication in it. So you really have to be careful. I have patients who swear by them. And as long as I counsel them as to what the risks are, and they feel better, then you have to kind of allow for patient autonomy in that way. But I think you really should talk to your provider if you are considering going down that route.
Any other questions, Paige, before we go to the last one?
Yeah. So for those hot flashes, is there a set time? Like, when do they stop happening?
That is a good question. So we do know that the majority of women, and I would say about 70 to 80% of women, will stop having hot flashes within 5 years of them starting. And I do have patients where they start and they stop and then they start again. But most women will follow into the category of they will be gone after 5 years. It's just getting through that 5 years.
Gotcha.
So is soy safe for us today?
Yes. So soy is approved to take, of course, all things in moderation. I wouldn't take the soy pill, the soy milk, the soy cream. I wouldn't do all of that. But yes, soy is something that has been proven and shown to mitigate hot flashes in a way.
A little bit.
So how long does menopause typically last?
So menopause, after you go through menopause, so once you've reached those 12 months where you have not had a period, menopause is for life. So you're not going to go back to being reproductive age after you've gone through menopause. So that is a transition that you go through. And once you reach it, you are postmenopausal. Your ovaries have stopped working. You are no longer ovulating. You should no longer be bleeding. And that's also the time where if you've suffered from gynecological issues like endometriosis, PCOS, fibroids, irregular periods, menopause is the period in time where those diseases should go away.
Okay. And then one more before we go to our last patient.
Okay.
Could you elaborate on dense breast tissue? What makes some women have more dense breast tissue?
Absolutely. So breast tissue is generally made up of mammary glands and adipose tissue. Adipose tissue is a big medical term for fat cells. And depending on your body type, depending on your genetics, what your mom was like, the ratio of that could be more or less. Now, what radiology determines as dense or not dense is really coming from their sort of parameters. But if they read one and they can't see the breast tissue very well, either because you have too much adipose tissue or too many mammary glands or fibrous tissue in there, they can then say that they're dense and they can't see what they need to see. And then you need to consider, and they will tell you, they should tell you that there's a different imaging modality that they should use.
Okay, got it. All right, we can get to our last patient.
Okay.
Here we go.
All right, patient number 5. This is a young woman, a 21-year-old. She comes in to see her gynecologist with a complaint of a new bump on her lady parts. She also isn't happy with the way things smell down there. Upset about this, she's been using Summer's Eve daily to help feel fresh, but it has not helped. And as for this bump, it hurts sometimes. She's concerned because she takes great care grooming this area, and she sees her esthetician monthly. So I kind of wanted to put a little tidbit in there about what they call down there care. We see this a lot. Sometimes less is more. Sometimes the things that we think we're doing to help are actually not doing things to help. So I'll first go on to say that everything that the good Lord put down there is supposed to be down there for a reason. So I will say that initially. However, we'll start with the bump first. So there's lots of different bumps that you can have on your bottom, and anytime you have a bump, it's concerning because you generally, when someone sees a bump, the first 2 things they go to is either it's a sexually transmitted disease or it's cancer. So if you do have a new bump, especially if it hurts, it never hurts to come on in, talk to your gynecologist, and find out what it is. Sometimes that bump is just anatomically supposed to be there. A lot of women, when they first take a look in that area, it's very concerning because they're not used to what they see. But if you do have a bump that hurts, it could be a couple of things. The most common thing that a bump down in there, especially for a girl who goes to her esthetician regularly, is folliculitis. Folliculitis is also known as hair bumps. They are very, very common. And for women who tend to shave in that area, especially for women of color, we see hair bumps frequently. And that's because when you take that hair out, when it grows back, especially in women of color, that hair will curl, and it can curl back into the skin. The skin will kind of grow over it, and then the bacteria in that area will get in there and cause a hair bump. They can get very big. They can be very, very painful. Generally, by the time a girl comes to see us, she's picked at it a couple times trying to take care of it herself, which can cause a bigger infection. So how do we prevent these? How do we keep from having these? Well, the first thing we always recommend, and it's not very popular when I tell patients, is to clip, not shave. So there is hair that's supposed to be down in that area, but you want it to be short but not gone. If you do feel like you want to not have hair in that area, for women of color, it's better to wax or better to laser, because then that actually treats that hair from curling in the hair follicles so that you decrease the amount of folliculitis. Also, there are products that you can use to help decrease the bacterial load on the skin, so that you don't end up with the folliculitis when the hair does grow back. And something else that I tell patients, and they always look at me like I am crazy, is that women are not supposed to sleep in underwear. I know that's a little odd for some people, but that area does need air to circulate. And when you sleep in underwear with all the covers on you, it kind of just lets everything simmer in that area. You also should be wearing cotton breathable underwear. Because if you wear an underwear that have colors in them, or some strange sort of lace or something, that can actually increase irritation, bacterial load, and things like that in that area. So that's for the bump. That's the most common reason. There's other causes. We won't deep dive into that today. I think I touched on sexually transmitted diseases. Cancerous bumps in young women are very, very rare, very, very rare. But again, if you have a bump, talk to your gynecologist and they can kind of walk you through that. The other thing I want to touch upon with down there care is discharge. So we see lots of women who come in with discharge and they're very concerned because their mind initially goes to a sexually transmitted disease. So we're going to go to that last slide, which is a great chart to kind of fish out what's going on and when do I need to see the gynecologist. So the vagina puts out a normal discharge. It's usually clearish, usually thin. It's not clumpy. It does not smell. There's no associated symptoms with the skin that goes on in that area, and the color of the skin does not change. And we do know that as you go through your cycle, as your hormones change, as you ovulate, the consistency of your discharge will change. And when that happens, that's when we see a lot of women come in thinking that they have an infection. Or some women make more discharge than others. That's concerning for women. But it's not pathological, and that's really difficult to get some women to understand. When we move into more concerning areas, there is a disorder called bacterial vaginosis, and that's when your discharge actually starts to change more creamy color white. It also can be yellowish. It's a little bit thickish in its consistency or creamy. And a lot of women will report that it smells, there's kind of like a fishy odor to it. There's no associated symptoms like itching or burning with bacterial vaginosis, and there's no changes in the skin color. So if you do see that, then that's probably moving towards bacterial vaginosis. I have found women, for some strange reason, do have sometimes recurrent bacterial vaginosis where we treat it, it comes back. We treat it, it comes back. And this is caused because there's bacteria that live in the vagina normally. They're supposed to be there. But when there's an overgrowth for whatever reason, stress, weight changes, what type of products you use down there, it can change the pH, and that can cause an overgrowth in the bacteria. I put that little nibbit about summer's eve in there because douching is not good. Some women think that it is, but what it actually does is it gets rid of the good bacteria that overthrow and keep the bad bacteria at bay. So we usually recommend that if you feel like you need to feel more fresh, just some a shower, a soap that has no dyes, no fragrances, and very, very mild is really all you need. If you're a bather, that's fine, but you want to watch what sort of products you put in your bath water that can shift your pH as well. And then the last one I want to talk about is yeast. Most women know about that yeast infection. Usually you find a clumpy white discharge and lots of itching. And that definitely should get you to see your gynecologist. There are some over-the-counter things that you can go to CVS or Walgreens and pick up and help treat over-the-counter. But I find that they're not as strong as they used to be. And sometimes when you use those, the symptoms will come right back and you need to call your gynecologist anyway. So sometimes it's better to just reach out to your provider and just get treated.
Great. All right. Wow, we covered a lot today.
We did.
We did.
So I was going to go, well, first before I see, because I know we're running out of time, I did want to cover that last slide really quick. You know, we have a lot of great OBGYNs in town. I'm sure that our viewers are connected to many of them, and that's great. But there is this new buzzword about, diversity and inclusion, cultural competencies, and the importance of, women wanting to see doctors, gynecologists that look like them. So what I put out here on this last slide is there are 8 of us here in town. Women of color who practice OBGYN. We are all around town. There are no men in this fray right now who are practicing regularly. And there's also no woman of color who's practicing OBGYN that comes out of Riverside or Dublin. So noting that on that screen. But I wanted to put that out there for you so that if you do want to connect with someone, these are some great doctors all throughout the city that you can connect with to get your questions answered.
Excellent. And here's your furry friend.
That's my Bailey.
Oh, he's so cute. And so, any other additional questions before we leave? I mean, we just such a great topic. I mean, I know we're going a little over, but we won't go too far over. Any other questions in the chat there, Paige? You're on mute, Paige.
Sorry about that. So I was just, for that list that you shared, can viewers just simply do a quick Google search and they'd be able to get in contact with them?
They can. They definitely can. You'll need to know what you're looking for. I don't know if there's any way to share that screen with our viewers. I'm not sure what the technical capabilities of that are.
Mm-hmm.
Yeah, we can do that.
But it's hard. It is hard for some women to find because those things aren't listed. So you really have to deep dive to find us.
Yeah.
We are out there.
Okay.
And then one last question regarding breast cancer risk factors and getting older, higher risk. Does it put you at higher risk?
So age is definitely a risk factor for breast cancer. The other things that are risk factors for breast cancer that you need to look for is your family history. So we do know that if you have a first-degree relative, so that's a mother, one of her sisters, one of your sisters, if one of them have had breast cancer, that increases your risk. We also recommend, if that's the case, that there is a genetic test called BRCA, which is BRCA. There's BRCA 1 and 2. So that is a genetic test that we do recommend for our higher risk patients to see if they also are at higher risk. And the other thing to think about is that usually breast cancer follows the maternal side, but if you have a father who had breast cancer, that also increases your risk.
Wow.
So that's something to think about as well.
People don't think about men.
You don't, but men can have breast cancer as well. And he is a first-degree relative, so that does increase your risk. So it is, I tell all my patients it's important to do your self-breast exams. Most women don't want to. They don't because they're afraid of what they'll find. Most women don't think about it. They're busy and they don't remember. But the best time to do your self-breast exam is really right after your period. Breast tissue is very, very lumpy, and it's less lumpy around that time. And if you do it every month, you'll know what you're feeling for. I usually tell patients breast tissue feels like lumpy oatmeal. So you're looking for a pea or a raisin in that oatmeal. And if you feel that, call us and we'll take a look at it for you.
I love your analogies. Those are awesome.
That English degree.
That English degree is working. I mean, seriously, it makes you think, oh, okay, I know what that feels like. Okay. Yeah. What about women who are past their menopause and no longer having a monthly period?
In terms of?
In terms of their breast exams.
Oh, yeah. So then what you do is you just pick a time. You just pick a time every month and you do it that time. Set a calendar. Everyone's got an app these days. And you do it. You could do it in the shower. You could do it in the bed. You could do it wherever you feel comfortable. And don't get too caught up in how you do it. I mean, there's the little shower things that are out there and you're like, go back and forth. And you really just want to cover all the breast tissue. You can go circles outward to in. You could go circles inward to out. You can go up and down, back and forth. The big thing is that you cover the entire breast on both sides and that you also feel under your underarms for any lumps or masses as well.
Oh, that's a good point. I don't think people think about their underarms.
Yeah.
Excellent. Excellent. So Dana, as we talked before, you want to just kind of summarize and just kind of close out here?
Well, the big thank you all for letting me talk to you today. I really appreciate it. I hope you were able to take some sort of nuggets away that you can use in your daily lives or go back to your gynecologist and ask questions. Don't be afraid to go to the gynecologist. Don't be afraid to ask the questions to get the answers that you need. And I wish you all safety. Be safe out there. Wear your mask, socially distance, get your vaccine when you can. And that's it.
Excellent.
Thank you.
Excellent. We're going to take that list that you, your last slide there, and put it up on our social media. I think it's exciting to know just the number of African-American women gynecologists and OBGYNs that are in the city. It is very exciting. Of course, we'd love to see that list grow, but that's a pretty impressive list. So we really love that, and we'll make sure we put that up there. And so yeah, so thank you, Dana, for all this great information. This was a wonderful discussion. Thank you, Paige, my co-host girl. All right. Yes, thank you everyone who joined us today. We really appreciate you being out there and actually keeping Dana on her toes, asking her all those great questions. We'll be back next week. And again, stay healthy and stay safe. Have a good night.
Bye, everyone.